So, ladies and gentlemen, my name is Sharon Whiteman, and I am part of the team at the Lyme Disease Association of Australia. And we've been advocating for action on behalf of sick Australians for 10 years now. And today, it's my great pleasure and privilege to have the final guest speaker, Dr. Richard Schloeffel, as our guest for today. Now, Dr. Schloeffel is a vocationally registered general practitioner. He's the medical director of the Grove Health Pymble in Sydney. For the past 23 years, Dr. Schloeffel has focused his practice in the understanding and management of complex and chronic disorders. Dr. Schloeffel graduated from the University of New South Wales in 1978. His initial training was in intensive care medicine, followed by an isolated rural general practice combining acupuncture and integrative medicine. He gained a fellowship in the Royal Australian College of General Practitioners in 1983, a diploma of acupuncture and Chinese medicine from China's Nanjing College of Traditional Chinese Medicine in 1986, and a fellowship of the Australian Medical Acupuncture College in 1987. Dr. Schloeffel worked extensively in rural general practice and in the developing world, as well as in Europe for 13 years, before moving back to Sydney, where he currently practices. Dr. Schloeffel was influenced by the HIV/AIDS epidemic of the 1980s and then the chronic fatigue syndrome and fibromyalgia in the 1990s. He then became increasingly involved in developing diagnostic and management pathways for these often misunderstood diseases. Highly influenced by the work of Professor Garth Nicholson's research into Gulf War illness, Dr. Schloeffel began establishing new paradigms in medical practice where stealth infections have been found to underlie many syndromes. Dr. Schloeffel's lectures on CFS in the 90s and 2000s rendered him one of the best informed authorities on these illnesses. In 2005, he was an integral member of the working committee of doctors who adopted the Canadian guidelines on CFS with Professor Kenny Demurier. In 2006, he developed guidelines on CFS, which are updated in 2012. Dr. Schloeffel was the founding member of the Australian Chronic Infectious and Inflammatory Disease Society in 2014, which was established to encourage education and research into vector-borne diseases, CFS, fibromyalgia, autoimmune disease, and chronic inflammatory response syndrome. He was previously the medical advisor collegiate with Professor Bernie Hudson, the head of infectious diseases at Royal North Shore Hospital, to the tick-borne diseases unit at Sydney University in 2014. He's been twice nominated for the Order of Australia Medal, missed out by a fraction in 2010. And in 2017, he was given the Order of Australia Medal in the field of chronic and infectious diseases for his work with CFS and vector-borne disease. Also that year, he was awarded the most outstanding health care professional in Australia in 2017 by the Australian Patients Association. Dr. Schloeffel was an expert witness in the Senate inquiry into Lyme disease in 2016 and was asked by the committee to prepare an evidence-based guideline for vector-borne disease in Australia, which was completed in 2017, but as yet is unpublished. He has been on all federal government advisory committees and meetings in relation to vector-borne disease. He was also present at the Council of Australian Government's COAG meeting in 2018 when the concept of DISCAT, disabling symptom complexes attributed to ticks, was proposed. Dr. Schloeffel is currently on the Lyme Disease Scientific Advisory Committee, the Emerge CFS Scientific Advisory Panel, the member of ELADS, a chairperson of ACIDS, and a medical advisor to DISCAT. He, with Professor Gilles Germain out of the Neuroscience Department at Macquarie University, Professor Eddie Holmes, microbiologist of Sydney Uni, and Professor Bernie Hudson, head of infectious diseases at Royal North Shore Hospital, have founded the Vector-Borne Disease Research Unit, publishing a paper on tick-borne diseases in Australia early in 2019. It was published in Frontiers on Cellular and Infectious Microbiology. Future research is proceeding into the diagnostics for vector-borne disease in Australia. Dr. Schloeffel continues to give lectures and master classes in CFS and vector-borne disease and autoimmune disease. He supports numerous doctors across Australia in the diagnosis and management of many complex patients who unfortunately have fallen through the medical system and as yet don't have a voice. Dr. Schloeffel, I know you're very busy. We tried for quite a while to get this time slot. I'm very grateful to have you here today.
It's a pleasure. Good morning.
So I love to hear that story of how you got into complex diseases, and especially how you were, the HIV/AIDS thing is very illuminating for you at the time. Tell us more about that.
Yes, look, my journey started a bit earlier than that. I was fortunate enough to go to Papua New Guinea in 1976 as a young medical student, just before I graduated. And I went to a small town in Milne Bay province, Alatau. And in this hospital I worked at, and there was only one doctor and us and 135,000 people. And there were large numbers of people with leprosy, malaria and TB. They had considerable resources at the hospital that had been provided by the Australian government, and there were many patients with TB and leprosy being treated, and the standard treatment at that time was 2 years of antibiotics, rotational, sometimes longer, and many of those patients were showing signs of recovery from the histories that I took when I was there. So that led me into some thought processes in regards to where would I go in medicine. So as a young med student, I thought, oh, look, I'll go and do intensive care. I ended up in a dark dungeon of Westmead Hospital. I thought, no, I don't want to do this. I wanted to study general practice, and I decided to do isolated rural general practice, work in the third world, and do extra study in China and Europe, etc. So in this journey, I met some patients who had complex disorders. I met my first chronic fatigue patient in 1981, and she was a very complex patient, had multiple admissions to hospital, multiple doctors looking after her. No one knew what it was. She had a massive gut disorder, gastroparesis, paralysis of the gut, chronic constipation, and I eventually found she had an infection in the bowel. I was able to treat that over a 2 to 3 year period, and she recovered. So my first journey was really this patient who said, and I thought, there must be lots of other people like this. And in the small country town I ended up in as a doctor, Bellingen in New South Wales, they had an epidemic of Giardia. And Giardia is a bowel parasite that can infest the gut. Often the symptoms aren't gut related though. People present with fatigue or depression or body pain. And we ended up treating nearly 2,000 patients in the early 1980s in the area with chronic Giardia, which they'd contracted from the local water supply. So seeing these patients and taking them on became an interest. And by 1983, I'd seen my first HIV patient who presented to me with a history of going to the bathhouses in San Francisco. He had an opportunistic lung infection. I had no idea about HIV or AIDS. But anyway, eventually he did receive a diagnosis and he did pass away from this illness. But I decided that at that point, I thought I'd take an interest in this developing disease. Unfortunately, in Australia in the 1980s, because it was mainly gay men, there was a bias towards not diagnosing, not even allowing these patients to come into medical surgeries. They weren't receiving treatment. Often they didn't have general practitioners looking after them. And until we actually got a viral diagnosis, clinics set up, individual doctors and then clinic doctors treating these patients, and women and children developing this illness, this group of patients was denied diagnosis and treatment, not dissimilar to what we're dealing with at the moment with vector-borne disease. And as soon as we had a viral diagnosis, we had some treatments developing, we had clinics, we started to recognise the pathogenesis, the disease process that these patients had. We could actually get them better, and many went into remission. Many of my patients that I saw in the 80s are still alive now. And we became very aware of all the treatment. The different drug companies produced a number of medication that was very useful, and triple therapies, etc., long-term. So we've got a concept already of long-term treatment for a chronic infection that we're not able to cure. And, I probably saw 300 or 400 patients in that time, and over 100 of my patients passed away in the early days from opportunistic infection. And they weren't all gay men. There were women and some children who were receiving blood products for their various conditions, and it was contaminated. So once that epidemic was brought under control worldwide, I developed a really keen interest on these sort of illnesses. And I was starting to see chronic fatigue syndrome patients more and more, because I'd seen a few over the years I'd been working in general practice. But it was around about 1993, I went to a lecture by Professor Garth Nicholson. And he is an American researcher, was employed by the United States government to look into Gulf War illness. Now that's a really interesting, for those who don't know about Gulf War illness, the Gulf War happened, countries were invaded in the Middle East. The soldiers were going across the plains towards Baghdad. The Baghdad cities were the silos where the germ warfare reagents were kept and various things were bombed. And as these military people were going across the plains and in that whole area, these infective agents went across these patients in these war grounds. And many people, there was only 150 or so people killed in the Gulf War, but tens of thousands developed this strange illness afterwards. And Garth Nicholson found that they had attenuated change mycoplasmas, chlamydia, pneumonias, other infections, which they'd acquired, which were very altered in their state, causing significant abnormalities and illnesses, even passing on to these veterans' children, and over 20,000 veterans died. So Garth Nicholson spoke about this, and I think he got into a bit of trouble through the government and whatever, but it stimulated a thought process that there must be something in this Gulf War illness, because these patients don't look dissimilar to the developing patient cohort that I was having with chronic fatigue syndrome, fibromyalgia. So those patients with chronic fatigue syndrome often had lots of unexplained symptoms, pain, cognitive dysfunction, headaches, mood disorder and whatever. And as they developed this disease, there didn't seem to be any answer. Garth was developing PCR testing, polymerase chain reaction tests. So I started to send some of the samples from these patients overseas, as he'd found these stealth infections in some of his Gulf War patients and chronic fatigue patients, and so did I. And the most common bacteria that I was finding was mycoplasmas, which I still believe today is the most common cause of chronic fatigue syndrome. It's just very hard to diagnose if you haven't got a proper pathological thought process to go with this. So I decided in 1997 to actually move forward into chronic and complex disorders, focusing on chronic fatigue, fibromyalgia. It wasn't by choice, it was by the absolute need to fill a niche in medicine, because even those days there was denialism of the disease, yuppie flu, and it was just psychiatric. And there was a definite pathogenesis occurring to these people that no one really had answers for. And I was very fortunate to give lots of lectures and meet lots of other scientists and doctors from all around the world in the 90s and early noughties, where I gained enormous experience in looking at chronic fatigue and fibromyalgia. So Lyme disease, I mean, I'll go into this, because I started to see all these patients, and I was seeing 300, 400, 500 people a year. It wasn't as if I was sitting on my backside hoping that someone else would come in. There didn't seem to be much support for these patients. And the classic story, like tick-borne illness patients, they were abandoned. And I started to work with them, and the ones I couldn't get better, I realised there was a possibility they had something else. And Professor Bernie Hudson sent me a patient with a diagnosis of Lyme disease in 1997 from a patient who'd been bitten by a tick in Norway, a deer tick, and he actually had proven Lyme disease, and we still use his blood and the reaction he had in his blood at the major hospitals in Sydney as our baseline for diagnosis. But he'd been denied access to treatment, even though he had a positive diagnosis. Bernie Hudson treated him for a year, and I treated for a month, and I treated him for several years afterwards. And he did eventually fully recover with some damage. So that's sort of how I got into this.
And so as you're talking, I can feel that, I was going to ask you some, your perspective on the politics of this, because it seems that patients are denied medical care when they're obviously sick, but it seems more like hearing you is that when there's an unknown around causation, or, the doctor is thinking, it takes a unique doctor to look beyond when something's a mystery.
I think with unusual patients, you have to listen. I have a very patient thought process, patient-orientated thought process. So when someone comes in with a complex history, I listen. And often within 10 minutes, I'll understand what's going on. I won't have a clear diagnosis, but I'll definitely hear this patient is very unwell. Often the first doctor ever to hear them and hear their story. And you need an hour and a half each patient to delineate all the symptoms, all the complexity, all the things that have been done before, which actually give you the answers but have not been recognised. So I think it's having a broad thought process and not jumping to a single entity, single diagnostic paradigm every time a patient walks in the door. Because none of these patients, whether it's chronic fatigue, fibromyalgia, even autoimmune disease and MS and whatever, people are complex. And vector-borne disease is very complex because you're dealing with viruses, bacteria, parasites from vectors and not just ticks. This whole concept of DISCAT, disabling symptom complexes attributed to ticks. Well, what about the lice? What about the midges? And some studies saying mosquitoes and bed bugs and march flies, possibly even leeches. We're starting to find tryptosomiasis in Australian leeches. So there's a whole lot of stuff going on out there looking at the different vectors that carry these illnesses. So narrowing it to ticks is a problem. So, but the thought process as a doctor, you need to be understanding this person's ill. People come in with their carer or their partner, their parent, and the child is 30 and there's parents sitting there telling the story because the patient is so unwell they can't remember or talk to you and they've got to lie down or they're fainting or whatever in the room or having a seizure. So all these things happen in your waiting room and then in your consulting room, which gives you an idea this person's very sick. And often they've had, I think you noted that there was 10 years from someone getting ill and to diagnosis in Australia. Now I've seen people 30 years. And so there's definitely, and often they're better within 12 months of treatment. So just being able to hear the patient and then have a thought process that actually thinks a little bit differently. So I think like this, not like this with these diseases, because you not only have to make a proper diagnosis, you need to actually resuscitate the patient. These people are very ill often if they've got a chronic form of vector-borne disease, chronic fatigue, fibromyalgia, MS, motor neurone disease, autistic spectrum disorder, chronic pain syndromes, Parkinsonism, a whole range of other illnesses that masquerade as really vector-borne disease. So you have to be open to that. I'm not saying all those diseases are caused by vector-borne disease, but there'll be a subgroup that are. And they're often the seronegative ones, the ones that just aren't quite right, don't fit that thought process. They don't quite fit into MS. They don't quite fit into motor neurone disease. And it's very important to have an open mind to be able to diagnose it. I think the politics arises, to be honest, because of the lack of diagnostic vigour. You know, when you've got people who have, say if someone's bitten by a tick and they develop an acute illness, they develop an erythema migrans, bullseye rash, which is classic in the United States. It does occur here, and I've definitely got lots of photos of people who had a bullseye rash, erythema migrans rash from ticks here in Australia. And we've even got evidence of Borrelia in some of our ticks, particularly relapsing fever, but I'm sure we're going to find Grignii, Bergdorferi and Afzelii in all our ticks, and particularly relapsing fever. But when we've got this diagnostic history and you're seeing someone acutely, if we join the dots, we can actually arrest the condition from progressing. So if we follow the guidelines, and part of the guideline problem is you've got two groups in America. You've got IDSA, which are the conventional infectious diseases specialists, which are really fine for making an acute diagnosis. Bullseye rash, been bitten by a tick, patient sick. Give them 1 week, 2 weeks, up to 6 weeks of antibiotics, often doxycycline in adults, clarithromycin in children, and those patients will recover. But where they fall short is that many patients, 20% or more, will go into this subacute or more chronic form, and that's when patients get missed. And if the belief is, oh, that doesn't happen, or it's post-Lyme syndrome, and that's the general consensus around the world because IDSA say so, that's a travesty in medicine. That's actually denial of a true diagnosis because they haven't actually done or read or established a thought process around evidence, which is already available worldwide, informs in this diagnosis of chronic vector-borne disease. In America, it's Lyme disease. We don't have Lyme disease here unless you're bitten by ticks in America, or you've got a European type of Lyme disease, or one in Africa or China or wherever I see my patients. And I'm sure there are patients who get bitten by American white ticks with Caribogdophori here too. But because it's got this stigma, Lyme disease, like chronic fatigue syndrome was, like AIDS was, there's an emotional response by doctors that shut down to the thought process that this person is chronically ill and could it be a vector-borne disease. So I think it comes really from belief systems that have impregnated the medical profession, because the education process and the dissemination of the real science, which is out there, isn't being disseminated through our colleges, the AMA, and particularly the government, and infectious diseases and then the other specialist groups. They're really holding on to their thought process, which in this day and age, I think, we need to be much more open to the development of new diseases, because we have a lot of things that are going to change over the next decade or two in the world with climate change and the increase in tick numbers with the temperature going up. If you increase the temperature in an area to 35 degrees on average, you'll double your tick populations. Your tick populations will come in to more residential areas, will move into country towns, will move into other areas, just because the vectors and the animals that carry them will be moving in. And if you've got a drought like we've got at the moment, we've got animals coming into residential areas just to survive. They're going to carry ticks, even though we need to look at 10 million ticks, not just 10,000. To actually find the bugs. We need different techniques of finding them. But if your thought process automatically cuts off that there could be any such disease, because that's what IDSA say, or infectious diseases specialists say, you're denying people diagnosis on a political ground, not on a scientific ground.
Mm. Yeah, it is non-scientific. I know as a former critical care nurse and then being a patient now for so many years, I can see, a real stuck place in medicine where doctors need have one disease, one cause, one treatment, and outside that seems to cause some kind of cognitive dissonance.
Oh, look, yes and no. Look, it's interesting. I'm chairperson of ACIDS. I've been doing this work for so long, and I've been teaching. I have master classes, full 50 doctors come every time. I have no trouble filling an auditorium of patients. I speak online, I get several thousand people listening to what I've got to say. And if I talk to my medical colleagues, now the reason I got an Order of Australia wasn't just patients and patient groups, it was my colleagues, my specialist colleagues, head of whole departments at major hospitals and university clinics who nominated me because they could see I was doing the work, because they send me their patients with these conditions. So it was really an accolade for something that was naturally happening. These doctors, most doctors, I think, are interested. They're just fearful of the implication of a few doctors who really want to shut down debate and shut down the doctors who diagnose and practice this style of medicine, because it doesn't fit into the easy concept of single-issue disease, single-issue treatment, which are pharmaceutically based or surgically based or whatever. And unfortunately, this is much more complex medicine. So I would say bring back the old-fashioned physician, which is how I trained, so we can actually understand the complexity and have a patient-focused approach as opposed to a disease-focused approach. The moment that's taught in undergraduate medicine and trained GPs and specialists are trained in this process, we'll automatically start diagnosing more and more patients with, vector-borne disease is in the differential diagnosis for these patients. How do we look for it? And that's the second problem I think we have, is the lack of diagnostic rigor. The CDC in America basically states that the diagnosis of vector-borne disease is purely related to the clinical presentation. It's a clinical diagnosis. In 40% of cases, you may get some pathology, ELISA test, Western blot, the so-called two-tiered results, which give you a positive diagnosis, but that's only used, according to the CDC, for surveillance purposes. It's never stated it was part of the diagnosis. So if someone's got a history of something that's bitten them, they're sick, they progress to a chronic illness, and it's unexplained and you can't find any other reason, top of my list would be vector-borne disease. top of other doctors' lists, they're malingering, or we don't know what this is, or we'll just try something else. Must be an aberrant form of some other syndrome, as opposed to going, oh, this could be vector-borne disease, which I prefer to call it. I think the L word, the Lyme word, is counterproductive because it's tainted with misconceptions and misunderstanding and righteousness by some doctors who are very limited in this skill. And they say in law and medicine, medical paradigms change with death and retirement. So I'm not particularly worried about the next 10 or 20 years. I think these diseases will be mainstream. Okay, but I think in the meantime, we've got a few vocal individuals who unfortunately propagate an ignorant sort of point of view, which is detrimental to the patient. That's why, and it's so difficult for us as doctors who want to practice high quality evidence-based medicine to deal with these complex patients. We're always watching our back.
What drives you to keep you going through that politicization and that?
Oh, look, I think, you know, I'm a patient folk. I'm a person who has great compassion for my patients. I think when I saw the difficulty of my patients in 1976 in Papua New Guinea, it's seeing children with TB and people, losing limbs and horrible things like leprosy, and then 400 people a day coming in with, malaria. I counted my blessings we lived in Australia. And when I worked in Australia, and then I started to see groups of patients that were maligned and abandoned, I thought, well, we're a first world country. We've got incredible intellect in the medical profession. We have incredible capacity to develop research paradigms that will help us understand something. We can throw 10 million at Zika virus, 3 cases. We have 250 to 300,000 patients with chronic fatigue syndrome, and they give a little bit of money here and there, including to people who just look at psychiatric components of these disorders. So there's a disconnect between those who have the power to change things and the ability to change it. So I think I have a moral, ethical, and a medical position to actually tell the truth. And truth in medicine is very important. When I trained, I learned about menopause when I did psychiatry. Now, as a woman, you'd say, that's nuts. Everyone knows it's a disruption of, your ovaries and failure of, estrogen, progesterone and DHEA and hormones dropping, and you go through. But it was regarded, there was a, psychiatric condition. Allergies and food sensitivities wasn't anywhere to be seen. People didn't know about that. So people were malingering, and people were told that, oh no, you can't be reactive to gluten. You haven't got celiac disease because the biopsy was negative. Now all that's long past. We know that gluten can do all sorts of things to the body other than just being a true celiac. People have gluten sensitivity syndrome. They get damaged gut wall. It's a predisposing factor for developing chronic fatigue and tick vector-borne disease if you carry the celiac gene or the MTHFR gene, you're an undermethylator. If you've got Ehlers-Danlos syndrome or Marfan syndrome or mitochondrial disorders, a whole lot of things that you see commonly amongst your patient groups, all evidence-based science, but totally missed when someone says, oh, you must be malingering, we don't know what's wrong with you. No one's looked hard enough. So I think there's a sense of laziness in the medical profession, which I don't have. And I think it's a need to put on the map a group of patients that unfortunately are going to increase in number with climate change. Even Tony Bertoni, the head of the AMA in Australia, the Australian Medical Association, came out and said climate change is the greatest threat to health in Australia. This is last year. And vector-borne disease is part of that. And I totally agree with him. I've tried to have a chat, and we will have a chat this year, and even this conversation is very important that gets to the doctors, the AMA, the College of GPs. So we actually start talking about that every practice in Australia has patients with chronic fatigue, fibromyalgia, unexplained, these other conditions, MS, autoimmune disease, and many of them will have vector-borne disease, and they go unrecognised. The other issue is the need to establish not only validated guidelines, but validated pathology. If you don't join the dots between the vector that bites you or the sexual transmission to some patients or the mother giving birth to a child who's born with a vector-borne disease. Now, I have been listening to lots of papers and to other doctors being interviewed around the world and reading lots of papers. And there's no doubt that these illnesses are sexually and and passed on, congenitally transmitted, horizontally and horizontal and vertical transmission. Now that's an extreme worry. Yeah. And if we miss those patients because we haven't thought about it, we primarily miss them because the pathology is not good enough. These diseases, the vector-borne diseases, of which there are many viruses, borreliosis, Bartonella, rickettsia, very common in Australia, Babesia, Ehrlichia, anaplasmosis, Q fever, mycoplasmas, chlamydia pneumoniae, all in ticks. Mm. Other parasites apart from Babesia, tryptosanes, tryptosomiasis, leishmania. All this is possible. And these organisms, they suppress the immune response, and often the body doesn't have a great immune response. So when you do the standard blood test, it's negative. And if you do a ELISA test, which is a screening test used in America, where we know there's 330,000 people diagnosed every year, and the test is 40% accurate. But in Australia, we don't even have that bacteria. Why would it be accurate? ELISA tests are determined, and so is Western blot, on the organism that you're looking at. And if we don't have that organism, those tests that are done in America, Europe, generally are not going to be very useful for Australia. So you do the pathology, it's negative, you've got a history, you've done a questionnaire, you know the patient's sick. No, you haven't got it, we haven't found it in the pathology. So in my mind, part of my role really is now to develop the science behind diagnostics. I think treatment is well known. I think there's some really good medical paradigms and thought process around treatment, which I'll come to shortly, but it's getting this diagnosis correct. And I've fortunately been asked to join Professor Gilles Guillemot, head of neuroscience at Macquarie University, who's just been given the Order of France for his work in biomarkers for MS. I mean, this guy's so credentialed. And Eddie Holmes, who's one of our scientific laureate microbiologists at Sydney Uni, and Professor Bernie Hudson, infectious diseases specialist, who I've been sharing patients with for 23 years or so. We know this illness is here. We even wrote a paper last year just summarising the science so far. And the gaps in the science are in pathology, in diagnostics. So we've formed a group where we're going to collect samples from 250, hopefully 1,000 patients once we're granted some funding, and actually do some metagenomic studies where we look at the bands, proteins and things that are present in blood, urine, spinal fluid, biopsies, joint fluid or whatever, and see if we can identify organisms from their base principles, as well as Eddie's work in that area and Gilles's work in biomarkers. So a whole range of biomarkers which are inflammatory markers that are used in MS and motor neurone disease, etc., that we can put into vector-borne disease, chronic fatigue, because many people have brain disorders in these conditions, and they look very similar. I think we're going to find very similar biomarkers. That work has not been done yet worldwide. So if we've got a diagnostic group of tests and we develop a group of tests that will help us diagnose rather than looking for immune response from patients, that will establish a paradigm that can be used worldwide for all the doctors and all the patients. So we stop the nonsense that this disease doesn't exist or it does exist, because the pathology will tell us exactly what we're dealing with and may even guide us to the next phase, which is treatment.
That's fantastic work, very innovative. And that, one of the things I constantly hear in this challenge in the time I've been involved is there seems to be such seeing innovation or emerging science globally as a threat to what is maybe status quo here in Australia. So it'll be good to have Australian innovation on this.
I think the lack of Australian research is actually inhibiting acceptance of the disease. I mean, I understand that Australia is an island. It's a pretty big island. We have people and birds and all sorts of migratory things that come here, and illnesses. People transmit their illnesses. We've got this developing illness in China at the moment, a SARS-like illness. Now, it's only a matter of days or weeks that it's here, but there are people bitten by ticks in Connecticut, come back to Australia, develop a tick-borne illness just like Lyme disease in America, but then won't get diagnosed because it doesn't exist in Australia, even though the history tells us that this person would have got it in America. So this way of thinking comes from the lack of pathology, the lack of thought process, lack of patient-focused thoughts, and the difficulty in how long it's going to take to work with that patient. I mean, I think we've created a situation in medicine where we're very time poor and we're captive to Medicare and whatever, and I think we have the best system of medicine in the world if you're acutely ill or if you've got a conventional illness. The moment you slip into something very chronic, even though we've now got NDIS and whatever, these illnesses aren't even recognised by NDIS. If you've got just getting chronic fatigue syndrome patients across the line, maybe. But if you say you've got vector-borne disease, you're not going to get NDIS. You're lucky to get government support through a sickness benefit or pension. You have to actually say it's chronic fatigue or something else to get it approved. So there's still lack of funding, lack of research, lack of clinical acumen by doctors. And I suppose my role is to have conversations like this. I know what to do. I know how to diagnose this. I know how to treat this. I definitely have, I'm very happy with my success rate. 70% of my patients recover to the point they can. And if you leave this disease too long, you'll have permanent damage. And many people are extremely damaged. 20% of patients I'll be able to help, but I can't cure. And 10% I won't be able to help. And some of those patients will have severe morbidity and mortality. And people do die from these disorders. And people can die acutely from these disorders. Bitten by a tick, and there's a few cases well known in Sydney and they were dead within a year or two, which was a progressive motor neuron-like disease that progressed into significant paralysis and weakness and then body failure and death. So, we're dealing with a very potentially serious illness in a small group of people, but it's a catastrophic illness in a much larger group because they become disabled, not able to work, not able to form relationships, not able to study, become a burden to their carers and family, become a burden to themselves. So as a caring sort of compassionate doctor with a good thought process, I'm ideal for this because I really think we owe it to the patient. It's all about the patient. It's not about the doctors and our belief systems or not. This is an evolving disease, as it was HIV. HIV patients, I can tell you, were abandoned. They weren't even allowed in the medical surgeries of many doctors. And there was no science behind that. That was just pure bias. It was a pure, and fear. I think most of this comes from fear. And I think gradually as the medical profession wakes up to the reality of these diseases and the science catches up with the observation, we'll be able to move forward.
And so we've pretty well covered the impact to patients on delayed diagnosis, which the LDA survey is average 10 years.
Yes.
And I know some of them, as you've mentioned, are much longer. Is there anything else you'd like to cover on the challenges with diagnosis and treatment that we haven't touched on?
Well, the diagnosis, I think we've still got to use the best evidence available, which is Australian labs, making sure that you take a history, do a proper examination, resuscitate the patient, treat the things that you see, correct their diet, check them for celiac disease, check their thyroid, because 30% will end up with Hashimoto's thyroiditis, underactive or overactive thyroid in some cases. Check them for developing secondary Addison's disease or adrenal failure. Make sure you treat their insulin resistance or sometimes what's called leptin resistance. Many patients put on a lot of weight, just as you see in other groups of chronic fatigue patients. So you can deal with and treat all this, deal with the pain, deal with the seizures. Specifically develop treatments safe to the patient that are based on evidence. Now, I speak to lots of colleagues around the world. I go to meetings. I'm a member of ILADS. I've been giving talks about this disease. I even mentioned tick-borne illness in the 1990s. So I think I was a bit of a pariah. And I remember going to a lecture in Sydney and talking about vector-borne disease and how that was going to be a problem in 20 years, 30 years hence if we didn't do something about it as a cause of chronic fatigue syndrome, because I'd already had these patients coming from Professor Hudson. So I was already thinking that way. But if you start treatment, and the majority of people can be treated with oral treatments, and that's not always antibiotics. Antibiotics have their place, and low dose continuous antibiotics like we use in acne or folliculitis or chronic heart disease where there's infection, or chronic pyelonephritis, or any other chronic infection, leprosy, TB, HIV. We have no question about how long we use them, and suddenly you get to this disease and you're a pariah and you're going to cause all this massive resistant antibiotics, antibiotic resistance. Well, it's not really true. We're using the majority of antibiotics used in these patients, I find, are the ones that are intracellular antibiotics that don't actually affect the cell wall. They're not going to develop a resistance factor on the cell wall. So you might use doxycycline or minocycline, azithromycin, clarithromycin, range of medication depending on the age group and the response to treatment. And you just slow and steady, and you may pulse the antibiotics, you may introduce other antibiotics in a low dose once a week or something. You may do triple therapy in the very sick patients, and if they're very ill, they may have intravenous treatment for pulse treatment, go overseas and have hypothermia. Now, over 1,000 patients, maybe 2,000 patients have gone overseas to Germany and Malaysia for hypothermia treatment, where we heat the body to 41, 42 degrees centigrade over many long periods in an intensive care situation, giving antibiotics at the time, supporting the patient under an anaesthetic, and patients generally will respond enormously well for that. It was found initially for borreliosis, Lyme-like illness, but it actually helped with Bartonella and Rickettsia, and even to some extent Babesia. And ozone therapies, which are done overseas, and particularly in Cyprus. Not many people doing it here without restrictions being placed on them. And then apophoresis, which is filtering the blood, which we used to do quite extensively in HIV patients when there was the last resort was to take out the blood, filter it and put some blood and products back in. And we use that obviously in cancer therapy and prior to stem cell therapies, a whole range of applications, but we're not doing it. But it can be done in Switzerland and some parts of the Balkans and in America and Mexico. So there's clinics all around the world and doctors all around the world working with Australian patients to do their best to help us. And meanwhile, we're asleep at the wheel. The medical profession in Australia has a lot to answer for in denying a real illness that's obvious but difficult. Just because it's difficult, we're very intelligent, very capable, highly skilled, highly educated group of people, the medical profession in Australia, and all the allied health that supports us. It only takes a thought process and a bit of governmental direction for us to change our thinking. And it worries me enormously that this investigation or suggestion that the DISCAT guidelines could be anything but an open-ended, we need to do raw research. There is no evidence around the world that tells us how to exactly deal with this. If we look at just the IDSA guidelines, we are going to fail our patients. It will cause extreme morbidity and extreme suffering of people not being able to be properly diagnosed and treated. And I believe it'll actually put people's lives at risk, which opens whoever's putting the guidelines together, and particularly the government, to legal attack, because you can't actually legislate a guideline that's not evidence-based. If you look at the ILADS guidelines, I think they're very amenable to Australia. And back in 2017, I wrote an Australian initial guidelines for Australian tick-borne illness, but which I haven't been able to, develop or publish, because that puts my group of doctors, ACIDs, probably me, at risk. Now, there's nothing in it that's contentious. A lot of it is actually contained in the IDSA guidelines, particularly for acute tick bites and things. But the chronic illness, we've got to go over to ILADS or some of the European guidelines. The German guidelines are very good, where you recognise there's a chronic form of this and you have to address it, and you treat it at whatever levels required with the expertise you've got, whether it's in your local surgery to specialist doctors. And I don't think infectious diseases specialists are primary to this disease, because there's so many other diseases it overlaps with. I generally find cardiologists, neurologists, immunologists, open-minded infectious diseases specialists all need to work together to try and manage a complex vector-borne disease patient, because they've got so many avenues of issues and so many difficulties, you can't manage as a single issue thought process in one area of medicine. You need all areas of medicine and a really good GP managing the whole process, carers, patient support groups, family members, and the patient being on board and educated. That's a big call, but that's what has to happen. You can't, you can't dumb this illness down to say, oh, you do a 2-tiered test, you've got to have a bullseye rash, and then you think that's the diagnosis. You see an ID specialist, that's done. If that's how these guidelines come out, that is extreme negligence and extremely dangerous to the patients. And I think what we should be doing is an open conversation with the guideline group, us, other doctors who are informed. Now, in Australia, I've personally treated probably 4,500, 5,000 patients with chronic fatigue, over 1,000 patients with vector-borne disease. I think the other doctors you've interviewed with Christian Perron and Richard Horowitz and Stephen Harris, we put us all together, we're probably up around 50,000 patients.
Absolutely.
I mean, that's an enormous wealth of experience. We're all saying the same thing. If we put us in a room, we'd all agree with each other. And I can't see how we aren't the experts guiding the world to wake up to themselves. We have a serious problem. The science is a problem in Australia because we haven't found the evidence in the text, but we've got to find the evidence in the patients and the other vectors that carry this disease. It'll all be over in a few years when we've actually done all that science. But in the meantime, you've got tens of thousands of people in Australia infected, affected by these diseases who need a proper guideline, proper medical support, and the doctors and their carers and all the ancillary people protected from people who really want to put restrictions on all this. That's not about benefit to the patients. That's propagating a belief system that's actually outmoded, is actually been supplanted by more recent evidence, by good quality scientific papers being produced all over the world that I think they choose not to read. So the political situation really comes from a lack of scientific vigour and commitment to it. And for those of us who are there, I don't mind if you don't want to be involved with treating this disease. This is hard work, but you don't deny the doctors nor the patients the ability to have care because you have a belief system not based in rigorous science. It's based in being biased, and that's a problem.
I know in our family, we've got 2 of us positive, DNA positive for Borrelia, different tick bites on the same property on the Sunshine Coast. One
Yes.
of us got a bullseye rash,
Yes.
and the other has a repeating 4-weekly type disseminated rash.
Yes.
So this is Australia, and this is happening. And for 18 years now, we've both been denied medical care as a basis. So what do you say to people like our family out there, to the patients that are experiencing this medical abandonment that you've been mentioning?
Oh, look, my heart goes out to you. I mean, I think that's a travesty, as it was with HIV. I think part of the need is for people like myself to speak out, but also I really want to get the science organised. I mean, I can't treat any more patients. I'm getting quite relatively old, and I can't commit myself to a patient for 5 years of treatment. But what I want to do is get the science out there, improve the education, run more seminars, publish more papers, develop diagnostic pathways that are repeatable, done by labs, covered by Medicare in an Australian condition, and then allowing the doctors who diagnose and treat this properly educated to treat patients without threat of being deregistered or put on some sort of restriction. I mean, that needs to be stopped, and that political will has to come from government. I mean, the health department and some of their advisors have a particular belief, which is really putting Australians who have these diseases at risk. That's not the way Australians work. I think we're the most benevolent and kind and aware and accepting group of people you could ever have. We've got 200 nationalities here. People harmoniously live together in general, and we all have a great lifestyle and we have a great healthcare system. And somehow we've drawn a line in the sand, said, oh no, these patients don't fit into that. We can't do anything for them. No, they can't have a doctor. They can't have care. They can't have NDIS. Well, there's something wrong with that process. I think there's it's political. And and I think it's driven by a small group of doctors who have that belief system. And I'm more than happy to get into a room and have a discussion with them. But really, it's our political masters and the ones who set precedent in medicine who need to change. And look, very gratifying here, Tony Bertoni coming out the other day and talking about vector-borne disease as one of our greatest risks. Same with the College of GPs is aware of this. We now have an integrated medicine group within the College of GPs, and most patients need an integrated medicine approach to treat them. A standard general practice 5-minute consultation isn't going to help you. We need people who set aside time to work with you. We've got the training here and we've got the education capacity already in Australia. We have hundreds of doctors, and I speak to hundreds of doctors who are treating people with vector-borne disease in Australia. Every one of them would say, please don't mention my name. Don't say I'm doing this. How can I not be caught out for helping my patients get better? Now, that's a travesty. What's that about? Is it because they're fearful that someone will, say, oh, you're treating a tick-borne illness. That doesn't exist. Oh, you shouldn't be doing that sort of treatment. Meanwhile, the patient's abandoned. To me, that goes against the Charter of Human Rights, International Charter of Human Rights, which we all have. As we have the right to diagnosis and treatment of diseases, and we're a signatory to the Human Rights Charter. So what's this? Why is there a separate thought process for this group of people, which is probably tens of thousands of Australians?
It is. And what do you say, is there anything else you'd like to say to those doctors who are possibly open-minded but fearful?
Oh, I think, look, the 3 things that are most important: continue to educate yourself. Read the papers, join groups like ACIDS or ILADS, attend meetings, talk to your colleagues, talk to your specialist colleagues like I do. As I said, I talk to specialist colleagues all the time, and they have no problem accepting someone with a vector-borne disease diagnosis, any of them. But I selectively choose out the doctors I refer to, but we're all on the same page. Listen to every patient who comes in with a chronic illness and put it in your differential diagnosis. Find out what's the best pathway to make a diagnosis. And I still use local laboratories, the Australian Rickettsia Reference Laboratory. Even though Professor Graves is not completely supportive, he's still producing good tests. There are some non-medical labs in Australia that are very good, and definitely use labs overseas if that's useful and the patients can afford it. But really remember what I said earlier, this is a clinical diagnosis. So if in doubt, the best thing for doctors to do, quietly give a month of doxycycline or minomycin, see if there's a response, and if there is, often once you've started treatment, the pathology will become positive because you get an immune response because you've killed some organisms which are stealth to the immune response intracellularly. They'll release proteins and things into the bloodstream, which you can do an ELISA or Western blot, and suddenly you've got a positive test. And the patient may have to pay a small amount of money to do that. The standard laboratories will not be able to do that for you. They require an ELISA test, and if that's positive, then they'll do the Western blot. If you ask for ELISA and Western blot with the Australian Rickettsia Reference Laboratory, they will do all tests for Bartonella as well, Rickettsia and Babesia, but very rarely do they find Babesia, but Ehrlichia and Anaplasmosis and Q fever. These things are common in Australia. They're known to be in our ticks. Often they're novel. So read the literature, attend the conferences, and look, travel quietly. Don't do anything heroic. Ask for advice. Refer to other specialists and make sure there's an awareness that, if you're out of your depth, call for help. Patients will often put pressure on you because they are frightened to lose you as their practitioner. So make sure patients are educated and whatever when they're seeing other doctors. Sometimes they need to be quiet about what's happening for them, just for their protection and protection of you. But don't stop treating it because you fear the system. The system will change. Righteousness in medicine it will disappear. Menopause, allergies, HIV, chronic fatigue, fibromyalgia, they're all real now. They've all got a proper diagnostic process. Vector-borne disease will be the same. And I have no idea what we're going to face with climate change and all the changes that are happening around the planet. I imagine it's going to be pretty catastrophic. So I think many of us need to be very open-minded to these rapid changes in developing infections and whatever. And we'll be able to meet the task as long as we, don't go into denialism as a way of, basically suppressing discussion and debate and science.
Well, Dr. Schloeffel, 1,000 blessings to you on behalf of the LDA and all Australian Lyme patients. Thank you so much for leading this team of amazing doctors, all the ACIDS doctors. What would you like to leave people with today?
Well, look, thank you for those kind words. I think the most important thing is for all patients out there with whatever they've got, whatever chronic illness they've got, whether it's related to vector-borne diseases or not, basically get a supportive team around you, your family, your carers. Find a doctor who's well-informed and compassionate. Keep putting your hand up and talking to those in power who can change things, politicians, local members, contact the health department, whatever. Don't lose hope because, necessity will lead to change. Necessity is the mother of invention. And, one of the things I learned many years ago was that, the things that I've seen change in 44 years of practice now, is that, our whole way of thinking will catch up with what we're observing. So the observation that we've got now with all of you being so ill will actually lead to a paradigm shift in medical support. And this conversation and the work of the Lyme Disease Association and these group of lectures will go somewhere towards that. I hope that these talks will go out to all the appropriate people, including the DISCAT people, who are putting the guidelines together, the Australian government, the AMA, the College of GPs, so we can have a proper discussion about these illnesses and diseases. And that will help you and protect you and hopefully lead you down a treatment paradigm, one that you get recognised, second you can afford, and there's a long-term process of support, financially and emotionally, into the future. I know that many of you are suffering and are not under the care of a doctor. And I'm working on that the best I can by the research I'm doing with Giles Gilmore and Eddie Holmes and Bernie Hudson. If we can crack some of the diagnostic processes in Australia for Australians and then internationally, this is a game changer. And I suspect if I had Richard Horowitz or Christian Perron or Stephen Harris in the room, we'd all be saying the same. The problem is in the diagnosis, and it's only a matter of time. So I wish you all the best, and I hope you do find a way forward, and I'll be backing you as long as I'm able to.
Thank you, Dr. Schloeffel. Thank you for your time.
It's been a pleasure and great to talk to you, Sharon. Thank you.